I'm Hoppy Kercheval for WVU Medicine, and this is the Boundless Brain. And today, we're talking about multiple sclerosis, MS. MS is a disease where, in my lay terms, your immune system mistakenly attacks your brain and your spinal cord, which impacts your nervous system. About 1 million individuals in this country are living with MS. It's a very serious and potentially frightening disease. Fortunately, we're seeing significant advances in understanding, diagnosing, and treating MS. My guest is Dr. Melanie Ward, Division Chief for Multiple Sclerosis and Clinical Neuroimmunology at the WVU Rockefeller Neuroscience Institute. Welcome. Good to see you.
Thank you. I'm very happy to be here.
I'm happy to have you here.
Yeah.
So I gave my lay definition.
Yes.
Why don't you take it from there with a more medical definition?
Well, you are basically exactly right. So MS is an autoimmune disease of what's called the central nervous system. So that is your brain and your spinal cord. And what happens in MS is your immune system gets confused. So the immune system's job generally is to fight off things like bacteria and viruses and keep ourselves healthy. Sometimes the immune system gets confused, and specifically in MS, it attacks this part of the nerve cells called myelin, which is a lining around the nerve. And I kind of compare it to like insulation around an electrical wire. It helps the signals get conducted fast. So when that myelin gets damaged, it slows down conduction between the nerve cells, and that can cause a lot of different neurologic symptoms.
So the messages get delayed or scrambled, is that right?
Exactly, kind of a delay.
Yeah.
Takes them longer to get where they need to go.
Yeah. So do you know why this happens?
Well, so the cause of MS is not 100% figured out, and actually it's probably multiple things coming together. So one of the biggest risk factors actually is something called Epstein-Barr virus. So that's the virus that causes mono. Most of us have been exposed to that virus somewhere along our lives, and lots of us never even have symptoms. But Epstein-Barr has actually been shown to be one of the biggest risk factors for MS. It's not a two-way street, so most of us would be positive for Epstein-Barr. Most of us don't have MS, but it does appear to be a big risk factor. Vitamin D deficiency has also been associated with increased risk of MS. Smoking is a big one that increases the risk of MS and also can increase risk of tending to do worse over time. Then there's a lot of other risk factors too, but there is not one cause that's been figured out, and it's probably not the same cause for every person.
Really? So there's not a cause.
Exactly.
It's contributing factors.
Correct.
That cause this to happen.
All coming together.
So when these messages are delayed or scrambled, how does that manifest itself? How does that manifest in how someone moves or behaves?
Yeah, lots of different ways. So it depends on exactly which part of the nervous system is being attacked. But it can be anything from vision loss, numbness, weakness, trouble controlling a person's bowel or bladder, incoordination, lots of different things, again, depending on kind of specifically where the damage is occurring. And that also can be different for every person.
Where the damage is occurring, you're talking about the lesions?
Exactly.
So explain that, please.
Yes. So when MS is causing kind of active inflammation, we will see lesions on an MRI. Those often show up as white spots. So I call them either spots or lesions, depending on my mood for that day.
Okay.
Basically, they are things we will see on an MRI that show us there is inflammation happening here, or there has been inflammation in this place in the past.
And I want to get to diagnosis in a minute. I want to get to that. But we don't know exactly what causes it. There are risk factors. And also, why is it more common? Why is MS more common in women than men?
So that's another thing we have not perfectly figured out. That's the case with a lot of autoimmune diseases, though, is they tend to be more common in women than men. So there's question, is it hormonal related? Are there other factors? It's another thing we don't have figured out 100%, but it for sure is an increased risk.
There are different kinds of MS. Relapse remitting, which is the most common, I believe. And then there's primary and secondary progressive. So in lay terms, explain the differences among those, please.
Yes, yeah. So relapsing is the most common, about 80% of cases. What happens in relapsing MS is people tend to kind of go along pretty stable for a while, and then all of a sudden, for whatever reason, they develop new inflammation, and that causes new symptoms. Again, vision loss, balance problems, any variety of symptoms. And then over time, that inflammation kind of settles out on its own, or sometimes we give specific treatments kind of in the moment to help settle that down in the short term. And then they may go along stable for a little longer and then have another attack. The progressive MS, people are not necessarily going to have that like boom, 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 I can put my finger on the time this happened or this happened. Tends to be more of a slow progression over time. There's a lot of overlap, so not every person with progressive MS is not going to have relapses, and same with relapsing MS, not everyone's going to stay perfectly stable. Secondary progressive is when a person starts as relapsing MS and then over time they kind of transition to more of a slow decline over time.
So this is a complex disease.
Mm-hmm.
It's a scary disease. You are a clinician, you treat patients.
Mm-hmm.
How do you have these what are your conversations like with people when you're diagnosing them or treating them? Give me some examples, because this is scary stuff.
Yes, absolutely. And the first thing I always say is the only thing you have to remember from this visit is it's going to be okay. So most people nowadays respond very well to MS treatments, but even in people who are having more trouble, there are always things we can do to be helping them feel better and function as best as they can. So I always start with that because it's very overwhelming, especially when someone is just getting diagnosed. And I feel like sometimes give the diagnosis and then I talk about treatments and we get really in the weeds, and I feel like sometimes it gets to be like the Charlie Brown teacher, like wah, wah, wah. Yeah, exactly.
Yeah. Because so all they're hearing is MS.
MS, right. Yes, and it's a scary word. Yeah. So anyway, that's the main thing to tell people. And then typically we talk about what we just talked about. What is MS? What kind of symptoms can it cause? And then treatment options. And that means both long-term treatments to prevent new problems from MS, but also treatments to help people function as best as they can day to day.
I want to talk about diagnosis because 50 years ago, the diagnosis, as I understand it, was almost like post-disease.
Yep.
We don't know what's wrong. Oh, now we know you have MS because we see what's going on here. Then we got to a point where MRIs to show, which we still use, to have scans that show lesions on the brain and spinal cord. But now there are biomarkers, signals, which is a big breakthrough in how we diagnose MS. So please talk about that.
Yes, absolutely. So a biomarker is kind of an objective measure of something that's going on in the body. And over time, we have developed much better biomarkers to be able to look at and say, okay, this looks like MS, this looks like not MS. This is how we can track kind of disease progression over time. The diagnostic criteria for MS were recently updated, and one of the biggest changes was incorporating a lot of those biomarkers. Some of them are specific findings we can see on MRIs with MS. Some of them are specific tests of things like eye function, and then some of them are labs we can check on spinal fluid that can be helpful too as kind of markers of MS inflammation.
Is that relatively new method of diagnosis, is that 100% accurate or just give you better information?
So I would say that nothing is 100% accurate, but typically when we take all together a person's story, their exam, imaging, labs, those kind of other things I mentioned, we can often be very certain if a person does have MS. Sometimes it gets a little bit muddy on, do they have MS or do they not? We're in a little bit of a gray area, but we can use all of that information to help us understand what's going on with a person now and help us decide what we should do in the longer term.
So expanding on that, how are you using biomarkers at Rockefeller Neuroscience Institute?
Yep. So one of the biggest changes from the last diagnostic criteria, we're incorporating a couple of imaging biomarkers. One is called central vein sign and one's called paramagnetic rim lesions, but those are basically kind of just some very technical things we'll see on MRI. So we have incorporated those into our kind of standard radiologic findings that the radiologists look for. We also have strong MRI scanners that can detect some of those changes because they can be pretty subtle, and in the past, it was very hard to see them. But we have stronger scanners and, again, specialized neuroradiologists who can really help look at those imaging things. There are some specific eye tests also that can be followed as biomarkers in MS, and those are utilized at the eye center at WVU.
Why eye test? That seems very different than the fluid of the brain or the spinal cord.
Yep. So MS, in addition to damaging the brain and spinal cord, can also damage this thing called the optic nerve, which connects your brain and your eyes. It's actually a really common area to be affected by MS. And sometimes a person comes in and we can say, yep, your optic nerve is inflamed. I can take one look at you and see that. Sometimes it's a little more subtle, though, and sometimes can happen kind of slowly over time. There are more sophisticated ways we can measure that nowadays. Again, one's called OCT and one's called visual evoked potentials. So those can be really helpful. One, to look for signs of damage that might help us make a diagnosis, and two, kind of track disease progression over time.
Yeah, let's talk about that, because these biomarkers can help you, not just about diagnosis, but about progression.
Yep.
And then if you can monitor progression, and you can affect treatment.
Yep.
Is that right?
Yes, exactly. So there are blood biomarkers also that can be used sometimes to help make a diagnosis, although they're not officially part of the criteria, but more so, help us to track how much inflammation is happening now. Is there kind of under the surface damage happening that we aren't picking up on looking at a person? Is a person responding to treatment? The main one is called neurofilament light chain. It's a blood test, not something we track on everybody necessarily, but it definitely can be helpful in specific situations.
How are you treating patients with MS?
Well, the good news is there are a lot of great MS treatments nowadays. So even back in my day when I was training, there were not nearly as many and as good of options as there are now. So the treatment strategy is different kind of depending on the person. But we used to start everybody on kind of older, maybe less effective, but really safe medicines, and then kind of bump them up the chain if they were having problems. We know very clearly now that if we get people on good, effective treatment early, they do better. So often nowadays, most MS specialists are drifting towards that. Let's hit people hard, good treatment, get things calmed down. They're better, more likely to do well in the long term. It's an individual for every patient, so there's no one size fits all. And then symptom treatment is a whole other track. So then we have to think about things like pain, fatigue, all of the kind of day-to-day symptoms that can come along with MS. Whole separate treatment talk.
Wow. Is there and you're primarily a clinician, but do researchers think is there a silver bullet out there for MS, or is it more just getting better at diagnosis and treatment, do you think?
So we don't have a cure yet, although very someday we might. I mean, there's so much research going on. But again, we do have really good data about the effectiveness of early intervention in long-term outcomes in MS. And someday we're going to have a cure, or we're going to have a treatment that we can give everybody and say, this will work perfectly for everybody. We're not quite there yet, but we have made huge strides.
And if somebody's out there and what would it, and maybe like in West Virginia, we know not everybody goes to the doctor regularly. And if somebody thinks something's wrong, what should they notice and that would cause them to go and say, I better go get checked for this?
So I would say the most common symptoms of MS can be things like vision loss. And usually when it's kind of all of a sudden MS inflammation, it's not subtle. It's I was seeing fine yesterday, and over the past couple days, now I can't see anything out of one or both eyes. Things like numbness or weakness, especially on one side of the body or the other, although definitely can be both depending on the location of the inflammation, balance problems or coordination problems. All of those things raise concern for MS. And not everybody with those symptoms is going to have MS, right? There's a million things that can cause all of those things. But it is always better to get checked out, be evaluated. If it turns out it's something else, easy, great. If not, the earlier we intervene, the better.
Why are you in this field, and what do you get professionally out of this?
Yeah, well, so I love neurology and I love MS. My favorite thing about both, I really like to get to know people. So in my world of MS, we tend to meet people when they're young and see them for years and years. So I really like getting to know people. Love it when people come back and I can say, oh, how was your sister's wedding? Oh, your baby's so cute. So I really like that. And then MS wise, I mean, it's been such a huge shift and we really have great treatments nowadays. And it is very important to me, especially for West Virginians, to try to make sure people are getting the best care possible as early as possible.
What's your affinity for West Virginians?
I love West Virginia. I'm from Cross Lanes, so near Charleston. So kind of born and raised, very loyal.
And you feel like you're making a difference then with these folks?
I do, yeah. I mean, I always say, like, my job is to make, my corner of the world a little bit better. So I like to think that I help people, hopefully.
Good for you.
Yeah.
Good for you. Thank you. We've been talking with Dr. Melanie Ward, Division Chief for Multiple Sclerosis and Clinical Neuroimmunology at the WVU Rockefeller Neuroscience Institute. If you need more information or have questions about MS, go to wvumedicine.org, wvumedicine.org. For my producer, Chad Ploche-Atkins, I'm Hoppy Kercheval, and thank you for joining us on this edition of The Boundless Brain.